Visual Disability, a resource book for teachers. Accession number E551. This book is being recorded for the sole benefit of visually impaired at the National Talking Book Library of National Institute for the Empowerment of Persons with Visual Disabilities, Divyangjan, 116 Rajpur Road, Dehradun. Published by National Institute for the Visually Handicapped, NIVH, Department of Disability Affairs, Ministry of Social Justice and Empowerment, Government of India. Compiled and edited by Anuradha Mohit Dalmia, Director, NIVH, Dehradun, and A.K. Mittal, President, AICB, New Delhi. Designed and printed at Large Print Unit, National Institute for the Visually Handicapped, NIVH, 116 Rajpur Road, Dehradun, 248001, Uttarakhand. Narrator Aradhana. Front page 3.
This book is reproduced in Daisy Digital Talking Book, Daisy Text Only, and Braille format for people with bona fide print disabilities by National Institute for the Empowerment of Persons with Visual Disabilities, Divyangjan. This book is created for distribution for the print disabled only and in accordance with the Marrakesh Treaty ratified by India on July 24, 2014 and Section 52(1)(ZB of the Copyright Act 1957. This accessible format production of the original publication is permitted to be used only by persons with print disabilities. Any further reproduction, distribution to any person without a print disability or any commercial use of this book is strictly prohibited and will be subject to legal action.
Forward. I'm happy to find that the National Institute for the Visually Handicapped has brought out this useful publication titled Resource Book on Visual Disability. It presents in a compact form information on a variety of issues and topics which have direct relevance to children and adults with visual impairment. The Government of India, through the Department of Empowerment of Persons with Visual Disabilities, has during the last few months introduced several new schemes and strengthened ongoing ones to secure genuine empowerment of persons with disabilities of providing reading material in Braille, especially textbooks, in the desired quantities through an innovative scheme aimed at the establishment of new Braille presses and modernization of the existing ones in the country. This resource book, through one of its chapters, has rightly stressed the need for bringing about a positive change in the mindset of the community with reference to visually impaired persons. Towards this end, the department has undertaken two important initiatives: a scheme for awareness generation and publicity for persons with disabilities, and a scheme of in-service training and sensitization of state government officials, local bodies and service providers. The revised ADIP scheme has enabled thousands of persons with disabilities, including a large number of the visually impaired, to obtain free of charge a much wider range of assistive devices. I sincerely hope that this resource book will further contribute towards strengthening our efforts to create necessary awareness and sensitivity about visual impairment issue among all stakeholders. I greatly appreciate the initiative taken by the officers of the department and the National Institute for the Visually Handicapped in undertaking this welcome initiative. I do hope and trust that through this publication and similar endeavors, we would be able to create the desired conducive and inclusive environment for our brothers and sisters with disabilities, to which we are all committed. Thawar Chand Gehlot. Front page 4 is blank. Front page 5. Forward. I'm happy to learn that the National Institute for the Visually Handicapped, NIVH, is bringing out a publication titled Resource Book on Visual Disability. Indeed, it is a very comprehensive publication depicting crucial facts and information regarding anatomy and physiology of the eye, implications of various eye diseases, data and demographic overview on visual disability, opportunities for education, vocational training, employment and social security schemes. The book also provides useful information on services for newly blinded persons, elderly blind persons, and blind multiply disabled persons. I believe that this publication will generate ideas that will help us to move forward in our endeavor to improve the quality of life of persons with disabilities. Dissemination of information is crucial in decision making. I'm sure that the detailed information available in the book will help not only the visually impaired persons but all the stakeholders. It will also serve as a ready reckoner for special educators, resource persons, rehabilitation professionals, and caregivers. I appreciate the efforts of the team that has made it possible to bring out this comprehensive volume. Krishan Pal Gurjar, 27th August 2015. Front page 6th. This page is blank. Page 7th. Introduction. It is an important function of our national institutes to act as clearinghouses for information pertaining to their specific areas of specialization. The present resource book, published by the National Institute for the Visually Handicapped, marks an important step in this direction. Over the last 2 or 3 decades, there has been a welcome paradigm shift to the rights-based approach towards providing services for the visually impaired and other categories of persons with disabilities. On the national level, this has been marked by the positive and favorable impact created for these groups by 3 important legislations: the Rehabilitation Council Act of India 1992, the Persons with Disabilities Act 1995, and the National Trust Act 2000. The ratification of the Government of the UN Convention on the Rights of Persons with Disabilities provided further impetus to our initiatives towards reaching out to a growing number of persons with disabilities. This has been greatly strengthened with the launch of a number of new schemes during the last few months. At the international level too, we are now in the 3rd decade of persons with disabilities in the Asian and Pacific region, 2013 to 2022. The first 2 decades were launched with the Beijing Proclamation in 1992 and the Bivako Millennium Framework for Action in 2002. There has also been the Icheon Strategy and the Ministerial Declaration in 2012, followed by the Outcome Document for Persons with Disabilities for post-2015 International Disability Inclusive Agenda adopted by the UN General Assembly in September 2013. Our government has been a signatory to all these landmark regional and international instruments, along with the Marrakesh Copyright Treaty for the visually impaired and other print disabled persons. It is a matter of great satisfaction that the new Sustainable Development Goals, SDGs, especially presently being considered for the post-2015 International Development Agenda, also mentions persons with disabilities under different goals, something which was sadly missing in the case of the Millennium Development Goals. Thus, A wide range of important developments have been taking place in the disability sector during the last few years. These have been greatly strengthened and diversified over the last few months. The present resource book makes a bold attempt at focusing upon these initiatives in the government and voluntary sectors with regard to the visually impaired in particular. I commend the efforts of the National Institute for the Visually Handicapped, especially its director, Ms. Anuradha Dalmia, for completing this resource book with a skill and commitment. I also commend the valuable contributions of all authors who are eminent leaders in their respective fields for enriching the resource book with their wide experience and expertise. My sincere appreciation is also due to Mr. A.K. Mittal for the valuable help provided by him in editing the resource book. I do hope this resource book will lead to the production of other useful publications by NIVH in the future also. Love, Verma. Sachiv, Secretary. Front page 8. This page is blank. Front page 9. Preface. Production of reading material for a sector representing low prevalence groups such as the visually impaired or, for that matter, any other category of persons with disabilities is a matter of great significance. This is particularly so in view of the fact that not much material is brought out for these groups, though the need for collection and presentation of information on issues concerning their well-being is repeatedly felt and is stressed. It was in this background that the idea of preparing a document to be titled Resource Book on Visual Disability was conceived at a meeting held in the Department of Disability Affairs, New Delhi, on 12th September 2013. At this meeting, the then Secretary in the Department and President General Council, NIVH, accorded approval to the design and basic content of the resource book and authorized the Director of the Institute to take further steps to produce it. The Director thereafter initiated action to contact the identified authors, requesting them to prepare chapters on topics assigned to them. Some basic outlines of material to be included in the chapters was also intimated to them. The resultant volume is now before us. The resource book is intended as a kind of ready reckoner for parents, student teachers, serving teachers, and other professionals as also service providers. The objective is to provide them some basic and essential information on various aspects of work relating to the visually impaired. The resource book, thus, consists of 12 chapters. These can broadly be divided into 4 segments for ease of comprehension and referencing. Chapter 1 to 4 provide an overview of basic information on anatomy and physiology of the visual system, including the process of seeing, major eye diseases and disorders in the country, definition and terminology, numbers and demographic characteristics of the visually impaired population in India, as well as attitudinal factors and different psychological implications of visual impairment. Chapter 5 to 8 describe the evolution, present status, trends and challenges in the fields of education, vocational training and employment opportunities for the visually impaired. Services available in these areas are sketched along with the special provisions for certain specific groups of the visually impaired population. Front page 10. Chapters 9 to 11 present the technology perspectives. Thus, simple and advanced technologies used for reading, writing, education in subjects like mathematics and science, as well as mobility devices and low vision aids are outlined. Also presented is information on how built environment can be made barrier-free and convenient for use by the visually impaired. The volume rounds up with Chapter 12, which gives basic features of various regional and international treaties declarations, and conventions concerning persons with disabilities. The chapters have been written by professionals who have long and distinguished experience in their specific areas of work. They have enriched their contributions by drawing upon, as appropriate, current research and scholarly writing in each topical area. Each chapter introduces the reader at the very outset to what is to follow in the subsequent paragraphs. The chapters also include extensive references to the work of others in the field and list supplementary resources, including web resources, for additional information. Wherever appropriate reference has also been made to the related provisions of the Rights of Persons with Disabilities Bill 2014, introduced in Rajya Sabha in February last year. Recommendations of the Standing Committee on Ministry of Social Justice and Empowerment contained in their 15th report are also mentioned as required. We hope the publication will prove a resource of great value for all its readers and stimulate them to look at the needs, interests, and rights of persons with visual impairment with much greater sensitivity, empathy, and motivation. Avanish K. Avasthi, Joint Secretary, DD, to the Government of India, Department of Empowerment of Persons with Disabilities, Ministry of Social Justice and Empowerment, August 2015. Page 11. Acknowledgements. The production of Resource Book on Visual Disability has truly been a collaborative effort. To begin with, I must state that the volume would not have been possible without the encouragement and support I received from the Department of Empowerment of Persons with Disabilities, Ministry of Social Justice and Empowerment. I am deeply grateful to the Honorable Minister of Social Justice and Empowerment for the insightful foreword received from him. I must also express my sincere gratitude to the former Secretary, Department of Disability Affairs, Ms. Stuti Kakkar, the present Secretary, Mr. Love Verma, and the Joint Secretary, Mr. Avanish K. Avasthi, for their valuable help and encouragement. Mr. Verma has been good enough to write the introduction and Mr. Avasthi the preface for this resource book, which are most stimulating. The resource book is the outcome of contributions by way of chapters from a number of distinguished and experienced professionals in the field. These chapters contain a reservoir of knowledge and insight, which are of inestimable value in appreciating the various dimensions of visual impairment and services for the group. My profound gratitude is due to them all. Chapter-wise they are: Number 1, Dr. Geetika Mathur, Medical Officer, National Institute for the Visually Handicapped, Dehradun. Number 2, Dr. S.R. Mittal, Professor in Education, retired, Department of Education, University of Delhi, currently Adjunct Professor, National Institute for the Visually Handicapped, Dehradun, and Ms. Monica Singh, Research Scholar, Department of Education, University of Delhi. 3. Dr. Swati Sanyal, Course Director, Durga Bai, Deshmukh College of Special Education, Visual Impairment, Blind Relief Association, Delhi. 4. Dr. Anita Julka, Professor, Department of Education of Groups with Special Needs, National Council for Educational Research and Training, New Delhi, and Mr. R.P. Singh, Assistant Professor, Department of Special Education and Disability Studies, National Institute for the Visually Handicapped, Dehradun. 5. Dr. I. Arivanandham, Research Officer, retired, National Institute for the Visually Handicapped, Regional Center, Chennai. 6. Dr. Bhushan Punani, Executive Secretary, Blind People's Association, Ahmedabad, and Chairman, West Asia Chapter, International Council for Education of People with Visual Impairment, ICEVI. Front page 12. 7. Mrs. Nandini Rawal, Executive Director, Blind People's Association, Ahmedabad, and Treasurer, International Council for Education of People with Visual Impairment, ICEVI. 8. Mr. A.K. Mittal, President, All India Confederation of the Blind, Delhi, and Treasurer, World Blind Union. 9. Dr. Sam Taraporwala, Director, Xavier's Resource Center for the Visually Challenged, St. Xavier's College, Mumbai. 10. Ms. Nirmita Narasimhan, Program Manager, Center for Internet and Society, Bangalore. In order to avoid duplication and overlap and for greater cohesiveness, we have taken the liberty of reorganization material in a few chapters. Some additional information has also been included for content updating. We hope our esteemed authors will be good enough to bear with us for these adjustments and will forgive us for any inadvertent omissions or errors. I am most grateful to Mr. A.K. Mittal, who has, at our request, carried out the responsibilities as the co-editor of the publication and coordinated various chapters with considerable skill and efficiency. I am also most thankful to Mrs. Meera Mittal for her meticulous work concerning net search and related matters. Last, by no means least, I am deeply appreciative of the assistance rendered by the concerned staff members of the Institute in finalizing the resource book. I look forward to receiving comments and feedback from readers on the material presented in this resource book, so that we could further enrich the Institute's similar publications in future. Anuradha Mohit Dalmia, Director and Editor, National Institute for the Visually Handicapped, Dehradun, August 2015. Front page 13. Contents. Foreword by Thawarchand Gehlot, Honorable Minister of Social Justice and Empowerment, Government of India, front page 3. Foreword by Krishanpal Gurjar, Minister of State for Social Justice and Empowerment, Government of India, front page 5. Introduction, Love Verma, Secretary to the Government of India, Ministry of Social Justice and Empowerment, Department of Empowerment of Persons with Disabilities, front page 7. Preface, Avanish K. Avasthi, Joint Secretary DD to the Government of India, Department of Empowerment of Persons with Disabilities, Ministry of Social Justice and Empowerment, front page 9. Acknowledgements, Ms. Anuradha Dalmia, Director and Editor, National Institute for the Visually Handicapped, Dehradun, front page 11. Chapter 1, Human Eye, Structure, Functions and Common Eye Diseases, Dr. Geetika Mathur, Medical Officer, NIVH, from page 1 to 26. 1.1, The Eye, page 1. 1.2, Size, page 1. 1.3, Cornea, page 2. 1.4, Conjunctiva, page 2. 1.5, Sclera, page 3. 1.6, Uveal Tract, page 3. 1.7, Iris, page 3. 1.8, Pupil, page 4. 1.9, Ciliary Body, page 4. 1.10, Choroid Coat, page 5. 1.11, Lens, page 5. 1.12, Aqueous Humor, page 5. 1.13, Vitreous Humor, page 6. 1.14, Retina, page 6. Front page 14. 1.15, Optic Nerve, page 8. 1.16, Stages Process of Seeing of Vision Development, page 8. 1.17, Common Eye Diseases and Their Functional Implications, page 10. 1.18, Diseases of Conjunctiva, page 13. 1.18, Xerophthalmia, page 14. 1.19, Cataract, page 16. 1.20, Glaucoma, page 17. 1.21, Retinitis pigmentosa, page 20. 1.22, Macular degeneration, page 22. 1.23, Refractive errors, page 23. 1.24, References, page 26. Chapter 2, Identification and Assessment of Visual Impairment, Professor Sujata Bhan, from page 27 to 48. 2.1 Importance of Identification and Assessment, page 27. 2.2 Indicators of a Vision Impairment, page 28. 2.3 Types of Assessment, Clinical and Functional, page 30. 2.4 Assessment of Visual Acuity, page 31. 2.5 Functional Assessment of Vision, page 34. 2.6 Structure of Functional Vision Assessment, page 35. 2.7 Tools of Functional Assessment of Vision and Skills, page 37. 2.8 Low Vision Assessment, page 41. 2.9 Portfolio Assessment, page 44. 2.10 References, page 48. 2.11 Web Resources, page 48. Chapter 3 Visual Disability, Definition and Demographic Details, Professor S.R. Mittal and Dr. Monica Singh. 3.1 Definition of Blindness and Low Vision, page 49. 3.2 Categorization of Blindness and Low Vision based on ICD-10 version, 2010, category H54, page 49. 3.3 Disability Certification, page 52. 3.4 Incidence and Prevalence of Visual Impairment, page 53. 3.5 Census of India, page 54. 3.6 National Sample Survey Organization, page 55. 3.7 Prevalence of Visual Impairment in India according to Census Reports, page 59. 3.8 References, page 70. Front page 15. Chapter 4 Attitude Towards Visual Impairment, Dr. Swati Sanyal, page 71 to 92. 4.1 What is Attitude, page 71. 4.2 Attitude Formation, page 72. 4.3 Why Attitudes Matter, page 72. 4.4 Myths and Stereotypes about the Visually Impaired, page 73. 4.5 Community Attitudes, page 75. 4.6 Parental Attitude and Attitudes of Sibling, page 79. 4.7 Attitudes of Visually Impaired Towards Themselves, page 82. 4.8 Attitude of Teachers and Peer Group, page 85. 4.9 Attitude Modification, page 86. 4.10 References, page 89. Chapter 5 Psychological Implications of Visual Impairment, Professor Anita Julka, 93 to 106 page. 5.1 Concept of Adjustment, page 93. 5.2 Factors Affecting Adjustment to Visual Impairment, page 95. 5.3 Visual Impairment, Losses and Limitations, page 95. 5.4 Effects of Blindness on Growth and Development, page 99. 5.5 Conclusion, page 103. 5.6 References, page 104. Chapter 6 Educational Opportunities for Persons with Disability, Professor Anita Julka, page 107 to 124. 6.1 Historical Developments, page 107. 6.2 Integrated Education, page 108. 6.3 Some Popular Models of Integrated Education, page 110. 6.4 Inclusive Education, page 110. 6.5 Constitutional and Legislative Provisions, page 112. 6.6 UN Convention on the Rights of Persons with Disabilities, UNCRPD, page 115. 6.7 Some Important Government Scheme, page 119. 6.8 Psychosocial and Educational Implications for Children with Visual Impairment, page 121. 6.9 References, page 124. Front page 16. Chapter 7 Vocational Education and Training, Dr. I. Arivanandham, page 125 to 136. 7.1 Meaning and Impact, page 125. 7.2 Historical Perspectives, page 126. 7.3 Vocational Education or Training Facilities, page 128. 7.4 Pre-Vocational Skills, page 133. 7.5 Areas in Need of Constant Attention, page 134. 7.6 Conclusion, page 135. Chapter 8 Employment and Placement of the Visually Impaired, Dr. Bhushan Punani, page 137 to 174. 8.1 Importance, page 137. 8.2 Some Significant Terms, page 138. 8.3 Avenues of Employment, page 139. 8.4 Unorganized Sector, Organized Sector, Open Employment, Special Employment, page 139. 8.5 Modern Placement Techniques, page 157. 8.6 Vocational Assessment and Work Preparation, page 157. 8.7 Selective Placement, page 158. 8.8 Job Clubs, page 159. 8.9 Workstations, page 160. 8.10 Social Reinforcements, page 161. 8.11 Job Camps, page 161. 8.12 Institutional Placement Services, page 162. 8.13 Use of Web Portal, page 163. 8.14 Employment, a Matter of Right, page 163. 8.15 The Persons with Disabilities Act 1995, page 164. 8.16 UN Convention on the Rights of Persons with Disabilities, UNCRPD, page 165. 8.17 Right of Persons with Disabilities Bill 2014, page 166. 8.18 References, page 172. Chapter 9 Services for the Elderly Blind, Newly Blinded, and Blind with Multiple Disabilities. Mrs. Nandini Rawal. 9.1 Introducing our Representative Characters, page 175. 9.2 Newly Blinded or Lately Blinded Persons, page 176. 9.3 Visual Impairment, Congenital or Adventitious, page 176. 9.4 About Adjustment, page 177. Front page 17. 9.5 Self-Concept, page 178. 9.6 Services, page 179. 9.7 The Elderly Blind, page 181. 9.8 Deaf Blindness, page 182. 9.9 Visually Impaired with Additional Disabilities, page 184. 9.10 Conclusion, page 189. 9.11 References, page 190. 9.12 Web Resources, page 190. Chapter 10 Braille and Other Reading Materials for Visually Impaired Persons, Mr. A. K. Mittal, page 191 to page 214. 10.1 Early Reading Modes, page 191. 10.2 Louis Braille, page 192. 10.3 What is Braille, page 194. 10.4 Relevance of Braille, page 196. 10.5 Braille Writing Devices, page 197. 10.6 Braille Production, page 199. 10.7 Braille Libraries, page 201. 10.8 Teaching Braille, page 201. 10.9 Audio-Video Resources, page 206. 10.10 Other Reading Modalities, page 206. 10.11 Role of Digitization, page 208. 10.12 Recorded Material Importance, page 209. 10.13 Conclusion, page 212. 10.14 References, page 213. Chapter 11 Special Modern Devices for Persons with Visual Disability, Dr. Sam Taraporwala. From page 215 to 228. 11.1 Braille, its creation and access, page 215. 11.2 Screen readers, page 218. 11.3 Optical Character Recognition, OCR, page 218. 11.4 Low Vision Aids, page 220. 11.5 Mobility Devices, page 221. 11.6 Maths and Science, page 222. 11.7 Audio Players and Recorders, page 225. 11.8 Daily Living Aids, page 226. 11.9 Details of vendors or manufacturers of some access technologies, page 227. Front page 18. Chapter 12 Barrier-Free Environment, Miss Nirmita Narasimhan, page 229 to 248. 12.1 What is barrier-free environment, 229. 12.2 What is accessibility and why it is important, page 230. 12.3 What is universal design, page 231. 12.4 Reasonable accommodation, page 232. 12.5 Physical accessibility, page 233. 12.6 Signage, page 238. 12.7 Restrooms, page 239. 12.8 Transport, page 239. 12.9 Visual contrast, page 240. 12.10 Tactile maps, page 240. 12.11 Auditory wayfinding, page 241. 12.12 Organizing and arranging home, page 242. 12.13 Accessibility of information and communication technology, page 242. 12.14 Do we have any policies in India mandating accessibility, page 245. 12.15 Access audit, page 246. 12.16 Web resources, page 248. Last chapter, chapter number 13, International Publications, Reports, and Declarations Concerning Persons with Disabilities, Dr. Bhushan Punani. From page 249 to 278. 13.1 ILO's Historic Convention, page 249. 13.2 Jomtien Declaration, page 251. 13.3 Unescape Declaration, page 251. 13.4 Beijing Proclamation, page 252. 13.5 UN Standard Rule on the Equalization of Opportunities for Persons with Visual Disabilities, 253. 13.6 Salamanca Declaration on Principles, Policy and Practice in Special Needs Education, page 254. 13.7 Bivaco Millennium Framework, page 256. 13.6 United Nations Conventions on the Right of Persons with Disabilities, page 257. 13.7 WHO CBR Guidelines, page 262. 13.8 Disability Status Report, page 266. 13.9 Incheon Status, page 269. 13.10 United Nations Outcome Document 2013, page 275. 13.11 Marrakesh Copyright Treaty, page 277. 13.12 Conclusion, page 277. Contents completed. Front page 19. In this page, Helen Keller's picture has been shown. Under this, it is written, I'm only one, but still I'm one. I cannot do everything, but still I can do something. And because I cannot do everything, I will not refuse to do something that I can do. Helen Keller. Front page 20. This page is blank. Page 1. Chapter 1. Human Eye. Structure, Functions and Common Eye Diseases. By Dr. Geetika Mathur, Medical Officer, National Institute for the Visually Handicapped, NIEPVD, Dehradun. In this chapter, the reader is introduced to the dynamics of the visual system. In simple terms, the structure and functioning of the human eye is explained, followed by basic information about signs and symptoms and preventive measures regarding common eye diseases and disorders. It is hoped that the information presented here will enable the reader to detect early occurrence of deviant eye conditions or problems. The eye. The human eye is one of the sense organs which enables us to see and helps in observing and learning about the world around us. We use our eyes in almost every activity we perform, whether reading, working, watching television, writing a letter, driving a car, cooking, and in many other ways. It also allows us to see and interpret the shapes, colors, and dimensions of objects in the world by processing the light the objects reflect or emit. The eye is also able to detect bright light or dim light. This delicate organ is surrounded on all sides by a bony cage called the orbit, which is a bony structure which encloses the delicate eyeball. It is in a shape of a pyramid and has the apex pointing inwards and the base in front. Size. The dimensions of the human eye differs among adults by only 1 or 2 millimeter. The typical adult eye has an anterior to posterior diameter of 24 millimeters, a volume of 6 cubic centimeters, and a mass of 7.5 grams. The eyeball grows rapidly, increasing to 22.5 to 23 mm by 3 years of age. By age 13, the eye attains its full size. The human eye is made of layers. These are like the onion skin, one below the other. Page 2. Here, the diagram has been shown of the human eye, in which cornea, conjunctiva, sclera, fossa, macula, optic nerve, retina, lens, iris, and pupil have been shown. Please consult your teacher or colleague for this diagram. Cornea. Cornea is the outermost layer of the eye. It is circular and transparent with a slight curvature outside, that is, convex in its structure. It is like a clear window. It has no blood vessels, hence it is clear and shiny. It is extremely sensitive due to number of nerve endings. It is 11 mm in circumference and about 0.5 mm in thickness. It is used for corneal transplants and not the whole eye. It is a powerful refracting surface and provides 2/3 of the eye's focusing power. And surrounding the cornea is another transparent layer called conjunctiva. Conjunctiva. It is the thin, transparent layer that covers the outer surface of the eye. When we look at the eye, this layer covers the white portion of the eyes. It begins from the outer edge of the cornea and covers the white portion of the eye and also the inside of the eyelids. Hence, it is divided into 2 parts. Bulbar, which covers the white portion of the eye. Palpebral, which covers the inner surface of the eyelids. Page 3. It is nourished by tiny blood vessels. The conjunctiva also secretes oils and mucus that moistens and lubricates the eye. And conjunctiva and cornea are the outermost layer of the eye. The conjunctiva covers the white visible portion of the eye, which is called sclera. Sclera, This is the white portion of the eye which is opaque, fibrous, protective, and forms the outer layer of the eye. It is made up of fibrovascular tissue. It gives toughness to the eye. Just below the sclera is the nourishing layer of the eye, which is called the uveal tract or coat or layer. Uveal tract. The uveal tract is the vascular middle layer of the eye. It is divided into three areas from front to back: iris, ciliary body, choroid. Iris. It is the colored part of the eye. Iris color is due to pigment cells called melanin, which give color to hair and skin also. It controls light levels inside the eye, similar to the aperture of the camera. The opening in the center of iris is called pupil. Iris is embedded with tiny muscles which dilate, that is, widen and constrict, narrow the size of the pupil. The dilator muscles are arranged radially like the spokes of a wheel along the length of iris and are called dilator pupillae. The constrictor muscles are arranged circumferentially near the edge of the pupil, called as sphincter pupillae. Page 4. Here, three pictures have been shown: bright light, normal light, dim light. That is, circuitor musculus contract, pupil, radial musculus contract. Dilator and sphincter muscles of pupil. Source: webmedia.unmc.edu. Pupil. It is a central space surrounded by iris on all sides. It increases and decreases in size when light is thrown into the eyes. Sphincter muscles, which lie around the edge of the iris, contract, causing pupil to decrease the size, and this occurs in bright light. Dilator muscles, which are arranged like spokes on wheel, when contract, cause increase in size of the pupil. This occurs in dim light. The pupil is hanging like a curtain with one end free and the other end attached to the ciliary body. Ciliary body. The ciliary body is made up of tiny muscles. Attached to one end of the ciliary body is iris, and behind that are tiny fibers called zonules or suspensory ligament. The lens present in the eye is suspended by the zonular fibers or suspensory ligament. These suspensory ligaments help in changing the thickness of the lens by shortening or lengthening the lens. This helps in changing the shape of the crystalline lens, leading to focusing the image on the retina for near and far objects. Ciliary body also produces aqueous humor, a clear fluid that fills the front of the eye. Page 5. The ciliary body continues behind as the choroid coat. Choroid coat. The choroid coat lies between the retina and sclera. It is composed of layers of blood vessels and nourishes the back part of the eye. It is connected to the ciliary body in the front. It does not allow any light to enter, thus helping in formation of better image on retina. Lens. Attached by the suspensory ligament is a biconvex structure called the lens, which is located just behind the iris. It is crystalline, transparent, and flexible. Hence, it has the ability to thicken and thin when seeing close and distant objects. The lens is encased in a capsule, which is like a bag and is suspended with the help of suspensory ligament. Its curvature of the lens is controlled by ciliary muscles. It is made up of transparent proteins called the alpha, beta, and gamma proteins or crystallines. It focuses the image on the retina with its ability to change its shape for close object and distant object. With age, the lens gradually hardens, diminishing its ability to thick and thin. The encapsulated lens is in contact in front with aqueous humor and behind with jelly-like vitreous humor. Aqueous humor. It is present in the space behind the cornea and lens, watery in consistency, and is called the aqueous humor. It is continuously produced by the ciliary body. Volume is about 0.31 ml. This fluid nourishes the cornea, the lens, and also gives the eye its shape. At the angle where the iris meets the ciliary body and sclera is a sieve-like structure called canal of Schlemm, which continuously drains the aqueous humor out. Page 6. Vitreous humor. The vitreous is a thick, jelly-like, transparent, colorless fluid that fills the center of the eye. It is composed mainly of water, 99%, and comprises about 2/3 of the eye's volume, giving it form and shape. 4 cc is the volume. The viscous properties of the vitreous allow the eye to return to its normal shape if compressed. Behind the vitreous is the photosensitive layer of the eye called retina. Retina. Source: sightsound.wikispaces.com. Here a diagram has been shown in which parts are lens, rods, cones, rods, retina, and then optic nerve. Multilayered sensory tissue lines the back of the eye and contains photoreceptor, rods and cones, which capture light and convert it into electrical impulses. These impulses are carried by optic nerve to the occipital lobe of the brain, where they are perceived as images. The photoreceptor on the retina rods, are approximately 125 million, spread through the peripheral retina and are extremely sensitive to light. They enable us to see in dim light, photopic vision. Cones are approximately 6 to 7 million in number. They function best in bright light, photopic vision, and also allow us to appreciate colors. There are 3 types of cones which are sensitive to different colors of light: red, blue, and green. Page 7. Here, the pictures of rod and cone have been shown. In the picture rod, these are the parts: outer segment of rod cell containing photosensitive chemicals, then nucleus. And in cone, outer segment of cone cell containing photosensitive chemicals, and then in the last, nucleus. Source: healthhowstuffworks.com. The cones are distributed in the central area of retina called the macula. Macula, it is an oval-shaped area in the center of the retina. Has a diameter of about 5.5 mm. Macula helps seeing details and perform tasks like reading, threading a needle, etc. In its center is a small pit called fovea, which has largest concentration of cones. Here a diagram has been shown. Angular separation from fovea in degrees. Source: hyperphysics.phy-astr.gsu.edu. Page 8. The vision is sharpest at fovea. When light falls on the rods and cones, they get stimulated and the stimuli is carried forward by the nerve fibers. The fibers unite and form the optic nerve. Optic nerve. Each optic nerve contains more than 1 million nerve fibers. It transfers visual information from the retina to the visual center of the brain, that is, occipital lobe. The optic nerve is about 47 to 50 mm in length and is divided into 4 parts. Intraocular 1 mm, intraorbital 30 mm, intracanticular 6 to 9 mm, intraacranial 10 mm. Where the topic nerve leaves the eyeball is called as blind spot. the area of no vision because the retina is absent in that area. Stages of vision development. At birth, the newborn baby is able to appreciate only the gross structures. For example, while looking at the face, they can see the outline but are unable to appreciate the details like lips and eyebrows, etc. At birth, the infant can focus till 1.5 inch and most of their vision is blurred. They learn to focus their eyes by looking at faces. For example, the mother's outline of the face will be seen by the child, but not the details like color of hair or shape of the eyebrows. At 2 weeks, the infant is able to notice gross colors. At 5 to 6 weeks, they start following light and would try and look at light in the room. After 2 months, they start to focus objects. They also start to follow objects, but they tend to lose their gaze and the motion of following the object is not very smooth. They can develop a reflex called the blink reflex. When an object is brought very close to their eyes, they tend to close their eyes. At 3 months, they are able to follow an object with a smooth eye motions and their vision fixates at an object when placed in front of them. They recognize faces, voices and objects, smile when they see familiar people. The social smile, as it is popularly known, is apparent now. Page 9. At 4 months, show interest in a small bright objects. The eye movements become smoother, that is, less jerky. They try to reach out for objects when introduced in their visual field, but not successfully. At 5 months, the hand and eye coordination improves and they grasp objects successfully. They look at things which they are holding in their hand, examine the object with eyes, and do not use it as object of play. At 6 months, shift attention from one object to another, start picking up dropped toys within reach. At 9 to 10 months, start imitating expressions and look around the corners of the room with not much movement of the neck. At 10 months, peripheral vision develops almost 80 degrees from point of fixation. Start looking at object from some period of time, that is, gaze fixation. At 1 year, visual acuity, that is, fineness of vision is present. Visual acuity improves and the child can see distant object and near object. At the end of the first year, there is improvement in seeing the fine details as the fovea is completely matured. Children should be introduced to bold letter books with high contrast and brightly colored pictures. At 1 year 6 months, is able to match identical objects, point to pictures in books, can differentiate gross colors, red or green or blue, but is unable to appreciate shades, can also see patterns on colored as well as white background, but the pattern should be large and should have good contrast. Usually, big, large, brightly colored toys, when introduced in their visual fields, are well appreciated by them. Process of seeing. The eyes helps us to appreciate the size, shape, and also the depth of an object. The process involves many structures of the eye which help in getting a perfect image which is appreciated by the human beings. When light rays from any source, could be the natural light or artificial light, falls on an object, it absorbs some and reflects the rest back, which enters the human eye through the cornea, the transparent round outermost central area of the eye. The cornea bends or refracts the rays which then pass through the round hole called the pupil. The iris or colored portion of the eye that surrounds the pupil dilates and constricts, making the pupil bigger or smaller to regulate the amount of light passing through. The light rays then pass through the lens, which actually changes shape so it can further bend the rays and focus them on the retina at the back of the eye. The retina is a thin layer of tissues at the back of the eye that contains millions of tiny light-sensing nerve cells called rods and cones. Page 10. Cones are concentrated in the center of the retina in an area called the macula. In bright light conditions, cones provide clear, sharp central vision and detect colors and fine details. Rods are located outside the macula and extend all the way to the outer edge of the retina. They provide peripheral or side vision. Rods also allow the eyes to detect motion and help us see in dim light and at night. The light-sensitive cells of the retina get activated with the incidence of light and generate electric signals. These electric signals are sent to the brain by the optic nerves, and the brain interprets the electrical signals in such a way that we see an image which is erect and of the same size as the object. Common eye diseases and their functional implications. The diseases commonly associated with the various structural components of the eye are described here. Number 1. Cornea. Infection of the cornea is commonly called as keratitis. It can be caused by bacteria, viruses, fungi, and parasites due to minor injuries like wearing of contact lenses for very long periods, causing abrasions on the cornea. Photokeratitis or snow blindness is caused by excess exposure to UV light. It can occur with sunlight, sun tanning lamps, or a welding arc. Exposure to sunlight reflected from ice and snow, it is commonly called snow blindness. Fresh snow reflects about 80% of the UV radiation. It is very painful and may occur several hours after exposure. It may last 1 to 2 days. Sunglasses with UV coatings can help protect against damage from UV light. Common signs and symptoms are eye redness, eye pain, excess tears or other discharge from eye, difficulty in opening the eye because of pain and irritation, blurred vision, unclear vision, sensitivity to light, photophobia, or feeling that something is in the eye. Corneal erosion or ulcer are followed by corneal opacity. Page 11. Keratitis, corneal inflammation. Infection produced by herpes virus which causes chickenpox, dormant in nerve cells of the human body. It can reactivate during lifetime and infect some part of the body, causing blistering rash, fever, painful inflammation of the affected nerve, and is commonly called as herpes. It can infect the nerve of the head and neck, involving eye, and infects cornea. Here, a picture of the eye has been shown. Source WIKI 514 by 278 jpeg.healthhype.com. Page 12. Eye donation. In India, there are large number of people with corneal blindness who can be cured by corneal transplantation. Number of corneal transplantation are successful and help in restoring vision in people with corneal blindness. Corneal transplantation in infants born with cloudy cornea can make a big difference to their lives. Eye donation. Eyes need to be removed within 6 hours after death and inform the nearest eye bank at the earliest. Keep the eyes of the deceased closed and covered with moist cotton. Switch off the ceiling fan, if any, directly over the deceased person. If possible, apply antibiotic eye drops periodically in the deceased's eye to reduce the chance of any infection. Raise the head end of the deceased by about 6 inches, if possible, to reduce the chances of bleeding at the time of removal of the eyes. Both old and young patients benefit from cornea transplants. Donation from living persons is not accepted. Page 13. Number 2. Diseases of conjunctiva. Number 1. Conjunctivitis is commonly called as pink eye and is due to inflammation of the conjunctiva caused by bacteria, virus, fungus, irritants such as shampoos, smoke, and pool chlorine or allergens like dust, pollen, smoke. Redness in the white of the eye or inside of the eyelids. Increased watering from the eyes. Thick yellow discharge which forms crust over the eyelashes, especially after sleep. Itching in the eyes, burning eyes, blurred vision, increased sensitivity to light, that is photophobia. Second, trachoma is caused by chlamydia trachomatis. Chlamydia organisms share properties of both bacteria and virus. Factors which are responsible for trachoma infection are poor hygienic and crowded surroundings like socio-economic status, shortage of water. Initially, it starts with mild conjunctivitis and cause discharge from the infected eye. The discharge spreads and is passed by hands, by clothing, or by flies that land on the face of the infected person. There is presence of follicles on upper lid and lower lid and also upper margin of the conjunctiva which enlarge and merge with each other, involving the whole conjunctiva. Gradually, these follicles have pus discharge followed by formation of a scar tissue. The scar tissue pulls the lid, causing the lid to turn inwards and along with it the eyelashes. This causes the eyelashes to rub against the inflamed bulbar portion of the conjunctiva and cornea, leading to corneal erosions and gradually corneal scarring and corneal opacity. Page 14. Here in this picture, an infected eye has been shown. Source: byebydoctor.com. Functional implications. Person suffers from severe pain, redness of the eye, gritty feeling like sand in the eye discharge and irritation in the eyes. Person suffers also photophobia, difficulty in seeing in bright light. Treatment. Antibiotics helps in controlling and curing the infection. The National Program for Control of Blindness (NPCB) has incorporated the Trachoma Control Program, which started in 1963. Safe strategy for trachoma control. S for surgery, A for antibiotics, azithromycin, F facial cleanliness, E clean environment. Number 3. Xerophthalmia. Xero literally means dry, and an eye condition leading to a dry eye is known as xerophthalmia. This is caused by deficiency of vitamin A, which is a fat-soluble vitamin found principally in the liver of fish, poultry, livestock, in eggs and dairy products. In vegetables and fruits, it is found as beta-carotene, which is converted in the intestine to vitamin A. After absorption, approximately 50% of the ingested vitamin A is retained and is stored in the liver and then transported where required. Page 15. Hence, deficiency of vitamin A could be due to conditions that interfere with ingestion, absorption, storage, or transport. Vitamin A is essential for, first, the formation of rhodopsin or visual purple by the rods. Second, maintenance of the epithelial lining of several structures like skin, cornea, conjunctiva, and lining of internal organs. Third, a fully competent immune response. The deficiency in vitamin A will affect, first, rods causing difficulty in seeing in dim light called as night blindness, and second, loss of luster and dryness of conjunctiva and cornea causing xerosis of cornea and conjunctiva. Table: Eye diseases due to vitamin A deficiency and their treatment. Affected part of the eye, retina, rods, leading to difficulty in seeing in dim light, called as night blindness. Treatment with vitamin A, reversible in 48 hours. Affected part of the eye, conjunctiva, leading to dryness of the eye causing difficulty in seeing, called as conjunctival xerosis. Treatment with vitamin A improves in 2 to 4 days. Affected part of the eye, conjunctiva, leading to foamy patch due to thickening of layers of conjunctiva, called as Bitort's spot. Treatment with vitamin A may take weeks, months to or might not resolve. Affected part of the eye, cornea, leading to dryness with corneal edema, called as corneal xerosis. Treatment with vitamin A, supplementation should start immediately and expert care. Affected part of the eye, cornea, leading to sharply demarcated ulcer with a scar formation, called as corneal ulceration. Treatment with vitamin A, supplementation and expert care. Source: Vision 2020, The Right to Sight, a manual for Vision 2020 workshops. Page 16. Here, a picture of eye has been shown. Source: glutenfreeworks.com. Bitort's spots are associated with active vitamin A deficiency and may remain unresponsive to vitamin A therapy. These lesions are limited to the temporal quadrant of older children, generally are sequel of old xerophthalmia. Number 4. Cataract. A cataract is an eye disease in which the clear lens of the eye becomes cloudy. The lens plays a very important part in focusing all rays of light onto the retina. Facts about cataract. Cataracts are very commonly found as a person gets old. A cataract can occur in either or both eyes. Individuals with a cataract is in one eye usually go on to develop a cataract in the other eye as well. Cataracts do not cause the eye to water abnormally. They are neither painful nor they make the eye itchy or red. If the lens is totally opaque, it is termed as a mature cataract. Any cataract that is not opaque is therefore termed as immature cataract. Most mature cataracts are white in color, hence commonly termed as Safed Motia, white pearl. Why does this happen? The lens is made of mostly water and protein. The proteins are arranged in a specific manner so the lens is clear. As we age, the proteins start to clump together, leading to a cloudy area in the lens. Gradually, this cloudy area becomes more dense, making it more difficult to see through, and we name the condition as cataract. Page 17. Causes: age. Congenital cataract, when pregnant mother develops infection by herpes, simplex rubella, toxoplasmosis, syphilis, or cytomegalovirus during pregnancy. Injury, blunt injury. Excessive exposure to radiation, X-ray, infrared radiation, as in glass blowers, or ultraviolet radiation. Diabetes is associated with the development of cataracts. Congenital cataract is a term when a baby is born with clouding of the lens. This may be present in one or both eyes and can be stationary or be progressive. Functional implications of cataracts are decrease in clarity of vision, which is not totally corrected with glasses. Loss of contrast sensitivity will be difficult to appreciate light-colored objects against a light-colored background. Disturbing glare. Halo may be observed around lights. Night vision will be diminished. Diplopia, that is double vision, may be noted in the affected eye. 5. Glaucoma. This is a disease which results in vision loss due to damage to the optic nerve. First, the visual field and then the visual acuity is affected. It is often but not always associated with raised intraocular pressure. Aqueous humor is constantly produced by the ciliary body. It fills the posterior chambers, that is, space between the front of the lens and back of the iris of the eye. It then flows through the pupil and reaches the anterior chamber, that is the space between the front of iris and back of cornea, and leaves the eye through tiny channels called canal of Schlemm, a trabecular meshwork. In most people, the drainage angles are wide open, although in some individuals they can be narrow. Page 18. For example, the usual angle is about 45 degrees, whereas a narrow angle is about 25 degrees or less. Here a picture has been shown, source medicinenet.com, in which trabecular meshwork, iris, cornea, lens, ciliary bodies have been shown. Types of glaucoma. Number 1. Open-angle glaucoma or wide-angle glaucoma. This is the most common type of glaucoma. Structures of the eye appear normal, but fluid in the eye does not drain properly through the trabecular meshwork. The drainage mechanism may become clogged with age or due to any infection, even though the drainage angle remains open. This leads to an increase in the amount of aqueous fluid inside the eye and raises the pressure in the eye. Second, angle closure glaucoma or narrow angle glaucoma. This type of glaucoma is less common but can cause a sudden increase of pressure in the eye. Drainage may be poor because the angle between the iris and the cornea, where a drainage channel for the eye is located, is too narrow. When the pupil dilates, widens or enlarges, the peripheral edge of the iris can become bunched up against its corneal attachment, thereby causing the drainage angle to close. Page 19. Who are at risk? Have a family history of glaucoma, have poor vision, have diabetes, take certain steroid medications such as prednisone. Glaucoma causes the damage to optic disc, which has nerve fibers, hence requires immediate attention. The first sign of glaucoma is often the loss of peripheral or side vision, which can go unnoticed until disease has progressed. Hence, consult a doctor urgently if loss in sight, vision, seeing halos around lights. The high intraocular pressure leads to corneal swelling, which causes the patient to see halos around lights. Headache associated with nausea and vomiting. Redness in the eye. If eye looks hazy, particularly in infants. Nausea or vomiting. Pain in the eye. Narrowing of vision. Tunnel vision. Challenges in diagnosis and treatment of glaucoma. People suffering from glaucoma are unaware of the disease and rarely seek treatment until they have lost a great deal of vision in one or both eyes. Glaucoma treatment usually does not restore vision or improve vision loss, but it can reduce further damage to vision. People sometimes stop taking medicines because they see no improvement in vision. Hence, persons have to be counseled regularly. Medical therapy is lifelong and therefore relatively expensive. Loss of vision is slow and progressive in both eyes, but usually one eye is affected more than the other. Since the other eye takes over the rapid vision loss of the affected eye, patient reports very late and by then lot of damage is already done. Page 20. Screening and early detection is very important. Persons having difficulty in reading at age 40 years plus should all be screened for glaucoma. Check cupping of optic disc and measure intraocular pressure. Family history of glaucoma, hypermetropia, shallow anterior chamber. Glaucoma in children. In 1 to 10% of children, glaucoma is the cause of childhood blindness. Prevention. Rubella immunization in females in the childbearing age. Early diagnosis and surgery. Regular follow-up of cases. taking oral medication to prevent progression of disease. 5. Retinitis pigmentosa. Retinitis pigmentosa is a hereditary disease caused by mutation of certain genes which send faulty signals to the retinal cells, leading to deterioration of the cells. It shows varied pattern of inheritance. Unaffected parents can have affected children. Affected parents can have both affected and unaffected children. Only males have the disease while female are carriers and will not have the disease. All children are not affected in the same way. Some may have mild and some may have severe symptoms. If it occurs in one child, all family members are at risk. Retinitis pigmentosa is characterized by the progressive loss of photoreceptor cells and a gradual reduction in the field of vision starting from periphery and progressing towards the center, eventually leading to blindness. Page 21. People may experience one or more of the following symptoms: night blindness or nyctalopia, tunnel vision, no peripheral vision, aversion to glare, slow adjustment from dark to light environment and vice versa, blurring of vision, poor color discrimination, extreme tiredness, bump in objects on the sides, find difficult to see the rim or the sides of the doorway, difficulty to see in dim light, difficulty in adjusting when entering from outdoor to a dim light room like movie theaters. Here, two pictures have been shown: normal vision, vision with retinitis pigmentosa. Source: OhioEyeCareConsultants.com. This disease is progressive and cannot be cured, but few options may help. Light avoidance, use of low vision aids to slow down progression, vitamin A 15,000 IU-day, omega-3 fatty acids, gene therapy. Page 22. Transplant retina research. Retinal implants or prosthesis is a man-made device to replace a damaged retinal tissue to take over the function of the dead retinal tissue and by electrical stimulation stimulate the ganglion cells. Or the visual scene can be captured by a camera which is transmitted via electromagnetic radiation to a small decoder chip located on the retinal surface. Electrical current passing from the electrodes stimulates cells in the appropriate areas of the retina corresponding to the visual scene. 6. Macular degeneration. This disease affects the macula, causing deterioration in central vision with loss of detailed vision and color vision. The disease starts in fovea and then spreads outside. Macula becomes grey-green mass of a scar tissue containing flecks of yellow or white. The flecks are deposit of drusen. The etiology or cause of age-related macular degenerations unknown. Causes are likely to be genetically inherited, but environmental factors may also contribute. Macular degeneration often runs in families. There are two types of age-related macular degeneration: dry, that is atrophic form. This type results from the gradual breakdown of cells in the macula, resulting in a gradual blurring of central vision. Single or multiple small, round, yellow, white spots called drusen are the key identifiers for the dry type. Wet, that is exudative or neovascular form. In the wet form of macular degeneration, newly created abnormal blood vessels grow under the center of the retina. These blood vessels leak, bleed, and scar the retina, distorting or destroying central vision. Macular degeneration symptoms. Symptoms of age-related macular degeneration include blurred or decreased central close-up and distance vision, which is often delayed because patients subconsciously ignore the eye with worst vision prior to development of the condition in the previously good eye. Blind spots or scotomas are a direct result of lost macular function. Straight lines look irregular or bent, called metamorphosia, and objects appear a different color or shape in each of the eyes. Page 23. Objects appearing smaller in one eye than the other, called micropsia, may also indicate a swelling of the macula. Refractive errors. A refractive error is an eye disorder. It occurs when the eye cannot clearly focus the image. The result of refractive errors is blurred vision, which is sometimes so severe that it causes visual impairment. The common refractive errors are: Number 1. Myopia, nearsightedness, can see near objects clearly but have difficulty in seeing distant objects. The individuals have too long eyeball relative to the focusing power of the cornea and lens, or when the lens and cornea lens are too curved. This causes the light rays to focus in front of the retina. Individuals have difficulty in reading road signs and seeing distant objects clearly, but will be able to do near tasks such as reading and computer use. Treatment. Myopia usually progresses every year and stabilizes by the time the child is in his or her late teens or up to the early 20s. It is difficult to stop progression of the disorder. Concave lenses which have a minus sign are prescribed to treat the myopia. Spectacles and contact lenses can be used as prescribed by eye care professionals. At the age of 18 years, laser surgery may be an alternative when the refractive error is stable. 2. Hyperopia or hypermetropia, that is farsightedness, have difficulty in seeing nearby objects but are able to see distant objects clearly. In these individuals, the eye is too short or the lens and corneas have a strong refractive surface causing the light to focus beyond the retina. The nearby objects appear blurred and distant objects are seen clearly. Treatment. Spectacles and contact lenses with a positive sign in front are prescribed for correction. Laser surgery is an alternative to spectacle at the appropriate age. Number 3. Astigmatism. Distorted vision resulting from an irregularly curved cornea, the clear round outmost central covering of the eyeball. Page 24. To understand the condition, it is like the corneal surface is not smooth but bumpy and irregular. Both near and distant vision are affected. Treatment. Glasses are prescribed for significant astigmatism. Contact lenses and laser surgery are alternatives to glasses at the appropriate age. Number 4. Presbyopia. The condition is seen in elderly persons. The person has difficulty in reading or seeing at near distance and doing tasks which require precision. It differs from the other disorders because it is linked to aging and occurs almost universally. The lens loses its ability to contract and relax. The person tends to hold reading material at a distance from the body, and it is commonly referred as disease of long arms. Treatment. Can be diagnosed by an eye examination and treated with corrective glasses. All refractive errors cannot be prevented but can be diagnosed by eye examination and treated with corrective lenses or glasses, contact lenses, or refractive surgery. Chapter completed. Page 25. In this page, 6 diagrams have been shown. First of all is myopia, normal eye. Then light focused in front of retina. Then corrected with concave lens. After that, normal eye, hypermetropia, light focused behind the retina. Then corrected with convex lens. Source: lens refraction diagram 500 by 538 jpeg.patient.co.uk. Page 26. Websites: www.medicinenet.com/script/main/art.asp ? article key 6738, www.medicinenet.com/script/main/art.asp ? article key 7812, www.stluxies.com/popups/lens.htm, www.allaboutvision.com, www.cdc.gov/parasites/acanthamoeba/gen/info/acanthamoeba keratitis html, emedicine.medscape.com/article/211214 overview, www.allaboutvision.com/contacts/acanthamoeba keratitis htm, www.physicsclassroom.com/class/reference. Chapter completed.